friends from Afghanistan for giving me this opportunity. And it's a pleasure to be here to address all of you tonight. And it's very warming to see how everybody is interested about knowing and learning more, despite whatever the circumstances back home. So as mentioned before, diabetic retinopathy is a very important topic, and next 40 to 45 minutes I'll be talking about it. Uh, if you have any queries or questions, you can stop me in between. It is a very highly specialized topic, and I feel that there is a mix of people here from different backgrounds. So I've kept it from simple to advanced topics as well, so that everything about diabetic retinopathy, from its diagnosis to management, is covered. So if you have any questions, feel free to stop me or discuss with me at the end of the presentation. So diabetes is basically a group of diseases which is characterized by increase in the blood glucose levels, and all of you know that it results from the defects in the body's ability to produce or utilize insulin, and it is divided into two types, that is type 1 and type 2. I feel all of you know that better than me. Now, there are a lot of complications that can occur because of this. And, like your heart is affected, your kidney, your nerves are affected. But what we'll be talking about is the diabetic eye disease or diabetic retinopathy. Now, it is basically the dysfunction of the blood vessels. It's a disease of the blood vessels, which is caused by long-term hyperglycemia. And it can occur in any type of diabetes, type 1, type 2, any sort of diabetes can lead to diabetic retinopathy. Uh, at a lot of times in the beginning, it is asymptomatic, that the patient has no issues at all. But if it is not identified or treated, it can lead to complete blindness in a lot of cases now. So I went through the idea of diabetes atlas, and the highlights from this was that the burden of the disease that we are going to have in the coming years is 10 million or more adults with diabetes will be there, and 19 million more adults with diabetes are undiagnosed when we compare to 2015. So it's a huge burden of diabetes that is happening, and we see that almost the cases are growing, doubling, tripling over the decades across the globe. Almost all of the countries and the continents are affected. And when we see around the world from 2000, with the number of cases that were there compared to 2017, it's almost 4 times the number of these cases. And if diabetes was a country, so it will be the third largest country in the world after China and India. So there's a huge number of diabetics around the globe. And of course, India, my own country, is also affected a lot. It is known as, the diabetic capital of the world. And interestingly, why it is also important for us, like countries like India and Afghanistan, like almost 80% of the diabetes occur in low or middle income countries like ours. And the number of deaths also are there because of diabetes. And the biggest thing is that in a healthcare system, it puts a lot of burden on this. So that's why for healthcare policymakers also, it's a very important disease to consider. So what we see that 1 in 3 living with diabetes will have diabetic retinopathy. So that's a big number. If you have 3 patients, at least 1 will have diabetic retinopathy. In India, 20%, we have a lot of data coming in from India. A lot of prevalence studies have been done. And it is seen that approximately 20% of all diabetes patient will have diabetic retinopathy, which is something close to 1 in 3. Now, what we see that this impact on the vision loss, why it is important, because it affects all aspects of life, in terms of the physical well-being, the psychology of the patient, his integration with the society, and because he loses independence and is unable to work productively, right? So this is a photograph of the retina, how a healthy retina looks and how a diabetic retinopathy looks like. So going to the pathophysiology, it is a microvasculopathy. So what it does is that it causes occlusion in the capillaries, and then it leads to retinal capillary leakage as well. So these occlusions are caused by thickening of the capillary basement membrane. There is abnormal proliferation of the capillary endothelium. There is increase in the platelet adhesion. The viscosity of the blood increases, and there is a defective fibrinolysis. So all of these things lead to occlusion. Now, once this occlusion occurs, so a blood vessel is occluded, the blood is not flowing, so there will be ischemia. Ischemia is basically where there is loss of blood. So this is the basis of diabetic retinopathy: occlusion followed by ischemia. So ischemia will do two things. It will cause an infarction. So that will appear as white colored cotton-like things in the retina, which are known as the cotton wool spots. And the other thing is that it will increase the level of VEGFs, that is vascular endothelial growth factors in the eye. Now, these VEGF growth increase in them will lead to neovascularization. So neovascularization is formation of new blood vessels, which will lead to further complications like hemorrhage in the retina in the eye. There will be fibrovascular bands or something which will lead to tractional retinal detachment, and something very damaging to the eye, which is neovascular glaucoma. So this is the whole spectrum of the disease there. So the other aspect was of the leakage. So this leakage is because the tight junctions between the endothelium gets impaired, the pericytes are lost, and which leads to the weakening of the capillary walls, and also the elevated level of vascular endothelial growth factors. Now, because of this leakage, there are several things that happen in the retina. That is, swelling of the retinal layers will appear. There will be, because of the leakage, there will be exudation there and deposits of something known as the hard exudates. And this also leads to a lot of hemorrhage that is formed in the retina. So this is, a very early picture of diabetic retinopathy, and at times this may pass off as a healthy eye. But if you look very closely, there are some red colored dots that you can see. I have zoomed this photograph for you. So these are not hemorrhages. They might look like hemorrhages, but these are known as microaneurysms, which are like small red dots on the retina. And this is caused by the swelling of the small capillary vessels in the retina. So this is basically just a swelling of blood vessel capillaries. And this is the earliest sign of diabetic retinopathy. And if you're not looking for it, so if you see a patient with microaneurysms, then you know that the diabetes has started its effect, and the patient should be kept in close observation. Now, the next stage happens is when you see slightly bigger retinal spots, which is not these are short, just like dots, and these are small bleeding from the blood vessels within the retina. So there are a lot of other several types of these hemorrhages. So these are these deep round hemorrhages which are known as dot hemorrhage, and something which is more fuzzy and superficial, which is known as the flame shaped hemorrhages. So it looks like a flame at times, so it is called as a flame shaped hemorrhages. Then we can have small dot and blot hemorrhage. This is a more imperative from it's a more severe form of the disease, and it should be at least 3 months, because you can have further complications in it. Now, these white seeing, this is what we talked about earlier. Because of ischemia, there are infarcts that are caused known as cotton wool spots. These spots, that is what also come along. And now we need to differentiate them from another white spots. So these are hard exudates that we talk because of the microvascular leakage. There is certain exudation, and these shiny pale white, yellow, sharp edged dots that you can see. So this is because of the fat deposits from the leaky fluid. So if you look closely, there is an outpouching in the blood vessel right here, which is known as a venous loop. So because there is some in the blood, that is why this is looking like this. So these all these signs have to be carefully monitored and documented by the ophthalmologist. Now, something when after ischemia, what happens is these tiny, small blood vessels are formed. Now, if you look at the caliber of the other blood vessels, it is quite big, and these lacy, fine blood vessels, the new vessels that are being formed. So this is a hallmark of more blood into the eye, and these new blood vessels are formed in response to that. And this is known as when it happens at the level of the optic nerve, it is known as NV or neovascularized disc. And when it happens elsewhere, it is known as NVE or neovascularized vessel. And when it happens elsewhere, it is known as NVE, that is neovascularization elsewhere. So these require prompt treatment with the help of lasers. Now, when all the signs that we talked about, it happens at the macula. Macula is the center of the retina, so that is known as diabetic maculopathy. So all these signs that we talked about, but when it is right there in the center of the retina, it is known as maculopathy. That is hard exudates, hemorrhages, microaneurysms, and these also need treatment and monitoring. So the proliferative form of the disease, we talked about NVD, when there is neovascularization at the optic disc, or when it is a little far from the optic disc, it is known as NVE, neovascularization elsewhere. Now, these small lacy blood vessels can bleed anytime and lead to bigger hemorrhages, which are known as pre-retinal hemorrhages, right? So all these again are a hallmark of the proliferative form of the disease, which is most severe form and needs lasers in these cases. Now, another term that we need to be aware of, it's a bit of an older term, which is clinically significant macular edema, or CSME. So the definition is when a thickening of the retina is at or within 500 microns from the center of the macula, or if you see hard exudates. So these are called as clinically significant macular edema, and this requires treatment as well. Now, more advanced form of disease in proliferative type is when you see these white bands. If you see clinically, they are white bands coming right from the retina towards the lens, which is known as tractional retinal bands. And the end stage kind of a disease is when neovascularization occurs in the iris and other parts of the eye, and which leads to something known as the neovascular glaucoma. And it is a very difficult disease to manage, and can, if unchecked, can lead to complete loss of vision and blindness in the patient, right? So there are other causes of blindness in the patient when there is vitreous hemorrhage, blood fills in the vitreous cavity. Of course, neovascular glaucoma. There's a specific type of retinal detachment which is known as diabetic tractional retinal detachment. And at times, at the end stage, there is ischemia on the retina, which is known as macular ischemia also. All these things are potential causes of blindness in these patients, right? So this is what an end stage diabetic eye disease looks like, which is known as phthisis. So the eyeball shrinks, becomes soft, and has zero vision. So this is what we are trying to save our patients from in case of diabetic retinopathy. So the basic grading, the international grading that we follow is when you divide patients between mild, moderate, severe, and the proliferative form. So mild is when you just see the microaneurysms, which I talked about in the first slide itself. Now, moderate is when there are more than microaneurysms, but less than the next grade. That is severe form of the disease. And severe form is when you see intraretinal hemorrhages, venous bleedings, and microvascular abnormalities. And when you see the neovascularization part, then it becomes like proliferative diabetic retinopathy. So prevention is something that all of us should, when we talk about the treatment of the disease, prevention is very important, right? Because all of these can, 90% of the diabetes can be, eye disease can be prevented if you do proper examinations and control blood sugars accordingly. So first is primary prevention, where you can, have strict control of the systemic parameters. Secondary prevention is when you can do annual eye examinations, and tertiary prevention, of course, is when we actually treat these patients. So The best form is, of course, if you control, counsel your patients that you can go blind with this disease, and you need to have strict glycemic control. The eye examination, I feel, despite whatever the guidelines say, when once the patient is diagnosed with a diabetic retinopathy patient, he as a diabetes patient, he should have an eye examination. The official guidelines say that in type 1 diabetes, you should can get it 5 years after the diagnosis of the diabetes, and in type 2 diabetes, as soon as possible after the diagnosis of the diabetes is there, and after that every 1 or 2 years. But again, it is very fluid, and the ophthalmologist, treating ophthalmologist, will take a call on how frequently the patient needs to come. So the ways to examine the retina is when you can do a retinal photography through a fundus camera. There is an indirect ophthalmoscope available, and there is slit lamp biomicroscopy through a 90 diopter lens that is there. So these are the three modalities which can help us look into the retina. These are very easy to carry around, and I feel all physicians and, of course, all ophthalmologists should have one of these so that they can look out for signs of diabetic retinopathy in their patients. Other advanced forms are when you have handheld fundus cameras and more advanced fundus cameras. It is very important to, it helps you in diagnosis at times, but it helps more in documentation, monitoring the progression of the disease, and also counseling the patients. Once a patient sees what a normal retina looks like and what the disease that he or she is having, then they become more aware of the treatment. This is the images from a study that we did where we got handheld fundus cameras and did diabetic retinopathy screening for our patients. There's a lot of artificial intelligence that is now coming in, a lot of deep learning models which can very efficiently diagnose diabetic retinopathy. So these can be bought and utilized at large scales. A lot of these models have offline AI in them, so you do not need an internet connection as such to diagnose these patients. And these are very sensitive nowadays to diagnosing. Accordingly, depending on the grade of the disease, these patients can referred and followed up. Uh, the other forms of imaging is, of course, we talked about fundus photography and its role. A very important tool is something known as an OCT, or ocular coherence tomography. In crude words, we say it's like a CT scan of the retina. So it gives you a cross section of all the 10 layers of the retina, and you can see. So this image shows us the diabetic macular edema that has occurred due to your diabetes. The other very important investigation is fundus fluorescein angiography, where we inject a dye inside the hand, and we can see diagnose diabetic retinopathy, and specifically the proliferative form of diabetic retinopathy, all where the leakage, microvascular leakage is happening. That area lights up. So this is all neovascularization that is there, and where you see that there is no blood, that is the area of ischemic areas are there, which leads to the formation of neovascularization. A more advanced technique has now come in, which is known as OCT angiography. So it is something like fundus fluorescein angiography, but you do not need to inject a dye in it. The machine does it by itself. So what are the things that can affect the progression of the disease and you need to monitor as physicians is the duration of the diabetes. It's said that documented that after 10 years, almost 70 to 80% of the patients will have diabetic retinopathy. You need to look at the HbA1c level, blood sugar fasting and PP, hypertension, dyslipidemia, hemoglobin levels, proteinuria, and these things. Again, what can delay the disease is good glycemic control, good control, and lipid lowering therapy. So there were a lot of studies that were done, large trials were done. So DPCT, the Diabetes Control and Complications Trial, told us for the first time that with good intensive glycemic control, you can reduce the amount of retinopathy that is there. And similarly, we saw the effects of blood pressure on diabetic retinopathy was also in the similar fashion. So it's not just important to control the sugar of the patient. These other parameters should also be taken into account when doing this. So, when treating these patients, what are the forms of the treatment that we have? We have certain lasers, which are green lasers. Then we have intravitreal injections that are available. We'll talk about them in detail. So two things that I want to talk about more today is something known as diabetic macular edema. That is when, because of the leakage of the fluid, there is edema in the retinal layers, and the proliferative form of disease and how to manage. I feel all physicians and of course ophthalmologists will know it, but all physicians and medical students should also be aware about these aspects. So this is what a diabetic macular edema looks like on an OCT image. These black cystic spaces that you see, these are the edemas. Now, I'll just talk about whenever we are diagnosing a disease, it's more about how we can manage it. So, diabetic retinopathy, DME, it needs a holistic care. By holistic, I mean that you need to hit the disease from all aspects. You need to have a thorough systemic evaluation. You need to clinically evaluate the patient. And based on what the evidences we have through various studies, we have to design a therapy for that patient. So systemic evaluation is very important. As I said, sugar has to be controlled, and less than 200 should be there. HbA1c is again an important aspect, but the other aspects that you also need to consider it that if a patient is on glitazones, pioglitazones, it will increase diabetic macular edema. So whenever you are advising glitazones for your patients, just you need to cross check if that patient has any diabetes, because it can worsen the diabetic macular edema and reduce the vision in your patients. And this should be considered. We also talked about blood pressure. Blood pressure needs to be controlled, and good control of BP will reduce the incidence of diabetic retinopathy by as much as 20%. So, and we also know that the injections that we talked about, patients with uncontrolled blood pressure will need more injections, which is a great burden on the patients. Now, hemoglobin is again an important aspect. The patient should not be anemic because there will be increased risk of diabetic retinopathy in these patients. Renal profile is very important, and you will see a more severe disease when there is deranged renal profile. And dialysis can also, reduce the DME, and the intravitreal injections that we talked about can adversely affect the kidney. So once the patient is on dialysis, you can plan dialysis right after injection so that its toxic effect on the kidney are avoided. So the intravitreal injections that we use are avoided in recent cardiovascular events. So this also needs to be considered. And these intravitreal anti-VEGF injections should not be given to pregnant females because it can have a teratogenic effect in these patients. Lipid profile is another important consideration because those white hard exudates that you saw in the images, patients with deranged lipid profile will have more of these. So pathophysiology we have already discussed, so I'll not go into the base more details. We'll go to clinical evaluation. This we have already talked about. Another thing that we need to know is OCT. On OCT, we talked about clinically significant macular edema, but now we use the term center involving diabetic macular edema or non-center involving diabetic macular edema. If the edema is right in the center of the scan, on the OCT scan, it is known as center involving DME. And if it is a little bit far, we call this as non-center involving DME. So this is what it is. On OCT scan, there are few other findings that are there, which is something large spaces, which is known as cystoid macular edema. When it is, when this elevation is there from the inferior layers, it is known as neurosensory detachments. And when you see some traction, something pulling on the retina, it is known as the tractional component of the DME. So there are certain biomarkers on DME. If there are ophthalmologists, they will know these things. So this is a bit technical. There's something known as disorganization of the retinal inner layers. If we see disorganization on OCT, it means that the patient will have poorer prognosis. The cysts talked about, larger amount of cysts that there are more inflammatory load, and the patient will respond better with intravitreal. Similarly, and neurosensory detachment, this elevation that you see, that will also respond better. Reflect there, these white spots that are there. These patients also have more inflammatory kind of a disease and need steroid treatment. So again, there are a lot of protocols that were there. So there are basically 2-3 forms of treatment are there when it comes to diabetic retinopathy. One is laser, and one is steroid injections, and one is anti-VEGF injections. So the protocol I told us about that anti-VEGF injections are better. Protocol T told us about which anti-VEGF injection is better, and similarly, protocol U told compared the steroid implant versus anti-VEGF injection. So one protocol I is important to know that when they compared these injections, they found that intravitreal injections are working better versus the lasers. Now, the Indian guidelines that are there, they say that when you see edema on the OCT scan, which is diabetic macular edema, the first line of treatment is in the form of anti-VEGF injections that should be started, right? The other form of treatment is lasers. In proliferative diabetic retinopathy, we need to do lasers. So when a doctor diagnoses a patient as a PDR patient or proliferative diabetic retinopathy, lasers have to be done there. And if we see macular edema, then other forms of lasers can also be done to the patients. This is what lasers, these white spots that you see on the retina, these are laser spots. So there are a lot of anti-VEGF injections that are there in the market, in the Indian market also and worldwide. We have something known as aflibercept, something known as Eccentrix, and something known as Avastin that is available. I'll not go into too much details about these. Now, protocol, there is something known as protocol T, which told us that the aflibercept injection performed better than bevacizumab and ranibizumab, and ranibizumab injection performed better than bevacizumab. So whenever if you see an ophthalmologist advising aflibercept, so that the patient will have a more severe disease, or the doctor wants to give the patient more duration of treatment, a longer duration of treatment, so they choose aflibercept, which is much more costlier than the other two drugs that are available. So what the Indian guidelines tell us, which is aligned with the international guidelines, is to start the patient on intravitreal anti-VEGF injections, and you have to give something known as the loading dose. You have to start with 3 injections at 1 month interval, and then take a call how to take the treatment forward. This at times to reduce this DME, that is diabetic macular edema, we also do something known as vitrectomy and ILM peeling. We remove the topmost layer of the retina by doing this surgery. So it's a very fine surgery done under microscope with microforceps, and we remove a 700 micron layer. This is, you can see me performing that surgery. So we remove that layer. So what it does is that it improves penetration of the drug, and you can see a better response in case of diabetic macular edema. So this is what it does. So a lot of patients don't respond to your first line of treatment. So what do we do for these patients? What we do is that after giving at least 3 injections, if the patient is not responding, we move to a better drug. So in the protocol, we knew that bevacizumab, the ranibizumab is better than bevacizumab, and aflibercept is better than ranibizumab. So we move on to a better drug if that drug is not working after 3 to 4 injections. right? And at times we perform surgery as well. And there are steroid injections also available, which help a lot in these patients. So we can give steroid injections as well to these patients, especially those patients who have had any heart issue, ladies who are pregnant, and if we see biomarkers on the OCT scan that we just discussed. One thing also should be there in general knowledge, that after performing cataract surgery, diabetic retinopathy can progress, right? So now what we do in our routine practice is that we ask the patient to control the sugar really well before cataract surgery, and we also give anti-VEGF injections while performing the surgery so that the diabetic retinopathy does not progress in these cases. Now, the second aspect of the disease is the proliferative diabetic retinopathy. It's a very difficult disease to manage, and we have seen the classification of the disease, and the last form is when you see a lot of these blood vessels that are forming. These lead to traction and bleeding, and which can actually make the patient go blind. So what we do is that, we diagnose it with the help of fundus fluorescein angiography and clinically as well. There are three main forms of treatment when it comes to this. One is lasers. The other is same as that, which is anti-VEGF injections. And a lot of times we have to do surgery for these patients. So these are the various forms of lasers that we have. We can do patient laser on the patient while sitting down, and we can do standing also. Uh, so what, in 1968, by Dr. Betham and Elio, they had seen that when there was scarring on the retina, these patients developed less proliferative form of diabetic retinopathy. So with the help of lasers, we scar the retina so that the progression of the disease is stopped in these cases. So that is how we do these white spots that you see. These are the lasers that are performed on the retina. So almost 80% of the retina we perform the lasers, and just leave the middle part, which is known as the macula, for seeing in these patients. So it works really well, and there are a lot of studies that were done, and lasers were found to be better. There are certain side effects. Patient can have pain. There can be worsening of the macular edema, because we are covering a lot of the retina with the help of the lasers. Visual field loss can be there. The patient can see some color vision loss also, and there could be a reduction in the contrast sensitivity and night vision as well. And there are certain severe complications as well, but this is like a permanent treatment to the proliferative part of the diabetic retinopathy. And once we perform 3 to 4 sittings, usually the patient's eyes are saved. So it's a very good tool to save the patient's eyes. So anti-VEGFs can also be given in these cases, but their effect is temporary, and you need to keep giving the injections for months after months, which becomes very expensive, especially in India, to do these things. So that's why in India, and I feel in Afghanistan also, lasers are preferred over injections in proliferative form of the disease. Now, a lot of times we need to do surgery for our patients. So once there's a lot of vitreous hemorrhage because of this neovascularization, there is bleeding in the cavity, vitreous cavity, which is preventing the patient from seeing. So we do that. Sitting nightly white spots, and we are unable to see the retina, then also we do it. Other is when there is tractional retinal detachment is developing, and there are bleeding and ARMs are developing and fibrovascular proliferations are developing, these kind of tractions that are developing, then also we do surgery. Now we need to understand that an ophthalmologist or a retina surgeon needs to counsel the patient, and physicians also need to tell their patients that, once you are going in for a surgery for diabetic retinopathy, you need to understand that you will not gain perfect vision. The idea is to stop the vision loss, and this is not like a cataract surgery where today you will get a surgery done and tomorrow you will start seeing well. It's a long battle, and most of the times patients do not get very good vision, but at least we are able to stop them from going blind in a lot of cases. So there are a lot of things that we need to look for in a patient who is going in for surgery. The patient should be fit. The anticoagulant should not be there. If there is cataract, we need to do a cataract surgery. We need to look at the amount of neovascularization that is there also. Something from anatomy, there's something known as vitroschisis when we are performing. There's a splitting between the posterior cortical vitreous, so that we need to know. There are a lot of adhesions that are developing, which is known as focal adhesions or multiple hammock-like adhesions or broad-based adhesions. So these are considerations when you are performing surgery. This will be more relevant for ophthalmologists. The basic goal of these surgeries, which I feel physicians and medical students should also be aware about, is to try to restore vision by removing the hemorrhage that is present, and to give lasers to the eye as well, so that we can prevent further development of the disease and to relieve the traction that is there on the retina as well. So the basic steps of these surgeries, it is very important for all of us to know, because a lot of time we see diabetes patients and they are very confused about the surgery. So you can also help and counsel them. So at times we give laser or anti-VEGF injections that we talked about before the surgery, and rest of the steps I will talk about. So at times we give injections to the patients. What these injections will do is that during the surgery, they will stop bleeding. So we usually give them around 1 week before the surgery and then perform the surgery, so it becomes very easy for us. And at times we do lasers also, in which does help us in similar ways. So this is a video of the retina surgery where we are cutting the vitreous. And this is a bit different from other surgeries where we start from the periphery and go towards the center. Now, this is something about membrane dissection. There are a lot of membranes that are formed. So if we go in the wrong membrane, we will hurt the retina. So we have to find the right plane. There are two terms that medical students can be aware of, which is known as segmentation or delamination. These are the basic principles of relieving the traction in tractional retinal detachments. So this is desegmentation, where we cut it in between. And when we cut it from the base, it is known as delamination. So we can delaminate with the help of scissors. This is where you can see that we are using intraocular scissors to cut these membranes. And then we can also use cutters to also cut. So if you can see, with the help of the cutter, I have desegmented this thing. So there's something also, just you can be aware of these terms, which is conformal delamination and fold back delamination. These are two other types of delaminations that are there. So at times while doing surgery, there's a lot of intraoperative bleed, which can be tackled with the help of increasing the intraocular pressure, performing diathermy over the bleeds, where with the help of cautery, we stop the bleeding. At times we perform lasers also to do this. So this is something known as endolaser, where we perform laser on the retina by going inside the eye. So the previous laser that we talked about on the slit lamp and while standing, the images that I showed to you, that is something that we deliver lasers from outside. And this is the laser that we go while surgery. So all these white spots that you are seeing, this is endolaser being performed on the retina. So at times when there is tractional retinal detachment, so the retina is detached, then we need to put it back. So we need a tamponading agent, something that can put pressure on the retina. So there are three forms of tamponades. One is silicone oil we can use, or we can use a gas. A short acting gas is SF6, and a long active gas is C3F8. And at times we also tamponade with the help of air as well in these cases. So there can be a lot of complications which can be dealt with accordingly. Now, before I end my talk, I have just compiled a few case-based scenarios that might help you recap whatever we talked about. So we'll just go case-wise, 5-6 cases, which will help you understand the disease better. So this first case is about a 50-year-old male. He had a diagnosis made 1 year back of diabetes. His vision is very nice, and he is metabolically stable, that his sugars are well controlled. So this is the image of the patient. And now you see that we do not see anything. We don't see any red dots or any hemorrhages or any white spots. So this is a absolutely normal retina. So the patient is non-diabetic. Since he was diagnosed as a diabetic patient, we need to follow him annually. So the message is that even if you see a normal retina, we have to keep a diabetic patient under follow-up on an annual basis, which is a must. That will save his vision for life. Now, case number 2 is a 50-year-old male, but his diagnosis was made 5 years back. Again, his sugars are normal, and he's maintaining very good vision, 100%, 6/6 N6. But you see these right small dots there. So again, these are microaneurysms. This is the first image that I showed you, and this says that it is an early form of diabetic retinopathy, and we can safely keep the patient under follow-up for 1 year, because this is the earliest sign, and it will progress very slowly if the patient is keeping good glycemic control. Now, third case is again a 50-year-old male, same patient, but let us assume that he is metabolically unstable, that he is not having very good control of his sugars. So now we are seeing a lot of other things in this. So this is a scan that I have shown where this is a normal scan, because we see that this dip is there and we don't see any black spots. So this is a normal scan. So this is a moderate kind of a disease, because apart from microaneurysms, now we are seeing some dot and blot hemorrhages, some cotton wool spots that are available, some smaller flame-shaped hemorrhages are also there. So this patient I would like to keep on a more frequent follow-up, say around 3 months at least, right? So because this can easily convert into a more severe form of the disease anytime. So we need to review the patient every 3 months. Now, fourth patient is similar, but a vision loss is there now, right? So this is the patient. We did an OCT scan and we see these black spots, right? So this is diabetic macular edema, and it is very close to the center. So it is center involving diabetic macular edema, but it is not having a lot of vision loss. Only one line the patient has lost. So we can review the patient after 1 month, repeat the scan, and if the vision deteriorates, then we can think about intravitreal injections for this patient. Now, our fifth case is a bit older, old diabetes, almost 8 years, and he has lost 3-4 lines of vision, right? And he is metabolically unstable. This is a more aggressive form of the disease that you see, and we see a lot of edema in this patient, these large cysts, black color cyst. This is center involving diabetic macular edema, and this patient needs anti-VEGF injections. So the usual protocol that I told you about, that we give 3 injections at 1 month interval, and then as per need, we will perform more injections. So the injections that are available is ranibizumab, and the newer ones like aflibercept or faricimab or Ozurdex. These are all the kinds of injections that are available now. So another patient, case 6, which is 60-year-old, 10 years old diabetic with 660 vision. So this patient has lost a lot of vision, and out of so many lines can only see the top line on our Snellen's chart.